Hello and welcome. In this video, we're going to be discussing neurocognitive disorders. This chapter is about disorders that were previously entitled delirium, dementia, amnestic, or other cognitive disorders in the DSM-4. The core features of these disorders are cognitive, characterized by syndromes of delirium, or major or mild neurocognitive disorders, including the ethological subtypes. All are caused by either a general medical condition, substance use, or a combination of those factors. So let's talk about delirium. It's characterized by a temporary condition that often follows a short, fluctuating course seen by symptoms of impaired awareness of attention, transient nature, disturbance in cognition, and is not better explained by a pre-existing or evolving neurocognitive disorder. So this individual would be delirious and be have impaired awareness or attention of where they are. They would be incoherent, right, and have issues with their cognitive functioning during that period. So the neurocognitive disorders are characterized by cognitive decline from a previous level of performance and do not occur within the context of delirium seen by, and again, this is evidence of decline in one or more of the following cognitive domains: complex attention, the ability to stay focused. That's the ability to stay focused. Executive functioning, ability to think abstractly or to like plan, initiate, monitor, stop complex behavior. Learning and memory, the process in which information is encoded, stored, or retrieved. Language, um, expressive language, or in one's ability to communicate with others, or using language, or how to one expresses their wants and needs to others. Perceptual motor, ability to receive, interpret, and respond successfully to sensory information. And social cognition, focuses on how people process, store, and apply information about others in social situations. The neurocognitive subtypes: Alzheimer's disease, prefrontal lobe degeneration, Lewy bodies, vascular disease, traumatic brain injury, substance and medication use, HIV infection, prion disease, Parkinson's disease, Huntington's disease, another medical condition, multiple etiologies, or unspecified. Distinguishing major or minor neurocognitive disorders. The distinction between mild and major NCDs rely heavily on observable behavior, but cannot also be tested by cognitive assessment. Um, but can be tested by cognitive assessment, such as a neuropsychological test battery. So mild NCDs require a modest cognitive decline to the extent that it does not interfere with the person's independence in everyday activities. We need to specify with or without behavioral disturbance. Cognitive decline in major neurocognitive disorders meet criteria when there is a significant impairment that's evident and reported by those who know the individual and interferes with independence to the extent that assistance is required. A specified behavioral disturbance and severity. We need to distinguish between probable and possible diagnosis. To close out this section, let's compare the DSM-4 with the Montague Active System to DSM-5. So dementia and amnestic disorder became major and mild neural cognitive disorder in DSM-5. DSM-5 has a new listing of cognitive domains, and there's new separate diagnostic criteria are presented for major or mild neurocognitive disorder due to various conditions, such as Alzheimer's disease, frontotemporal lobar degeneration, Lewy body disease, vascular disease, traumatic brain injury, substance medication induced, HIV infection, prion disease, Parkinson's disease, Huntington disease, and other medical conditions, and multiple etiologies and unspecified. And substance and medication induced neurocognitive disorders and unspecified neurocognitive disorders are new diagnoses.